my heart because we get a lot of referrals of patients with positive ANAs and other serology without a clear diagnosis, and we have to try to sort out what may be going on. So these I've terminated actually speakers' relationship with Sanofi. So the objective of today's talk would be, how do we approach a complex multi-system rheumatic disease? Because that's really where we get the labs, right? The arthritis panel and all kinds of tests. I would add the statement to always think fibromyalgia, and I'll come back to that. And then I'll talk about how to evaluate someone with truly an inflammatory arthritis. What is the role of ANA in lupus diagnosis? And how do the ANA determinants help us lead to a connective tissue disease that is correct? And then finally, most importantly, why you should never order an arthritis panel. So I start with the case KM, 45-year-old woman working part-time as a police officer. When I saw her, she related that she was in excellent health until about 5 years ago when she had a bout of pneumonia that was treated with antibiotics, and she improved right away. But following that, she started to get bouts of severe fatigue, muscle weakness, constipation, diarrhea sometimes, pain when she urinated. She has swollen glands in the neck and axillae. She was able to go back to full-time work 3 months later in July, but she had residual fatigue and generalized soreness. 2 months later, she had to go on part-time because symptoms got worse with more fatigue. Now she has sore throat, headaches, spots in front of her eyes, chest pain. She got memory lapses, sweating, and she was seen, and the examination was entirely normal by her HCP, other than tenderness on the chest wall. Laboratory study, CBC, urinalysis, etc., all came back normal, but she had a positive ANA of 1 to 80 with a nucleolar pattern. I'm sure you see this all the time. You do this panel because you have people with multi-system complaints, and then the ANA turns out positive. So I saw her 5 years after that, and she continued to have complaints of severe pain and swelling in her hands, generalized stiffness lasting over an hour in the morning. She said her joints didn't move well. She couldn't grip objects without pain. She had severe fatigue, slept 6 to 8 hours at night, but she didn't feel refreshed in the morning. Her arms and legs felt heavy and weak. She continued to have memory lapses, difficulty with simple calculations, dry eyes, dry mouth, and a frequent cough. And she said that when the weather turns cold or hot, her symptoms were more severe. Over the years, she has tried different treatments, and they all didn't really do anything. So at the time I saw her, she was only taking a statin. So what goes through my mind when I get this history? She has morning stiffness, pain in her hands and feet. She has difficulty moving her joints. She said her hands are sometimes swollen. Could she have rheumatoid arthritis? On top of which, she also complains of dry eyes and dry mouth. Could she have Sjogren's syndrome? Could she have lupus? Lupus is the quintessential multi-system disease, right? Could she have Lyme disease? Well, fortunately, we're in Southern California, so Lyme is not a major consideration. But if you're practicing in Connecticut, for example, could this be chronic Lyme, whatever that is? Could it be an inflammatory myopathy? Probably not, although not impossible, because polymyositis can also present as an arthritis, and dermatomyositis can present with rashes. Could she have statin myopathy? Probably not enough to explain all her symptoms. So what do I do? Well, the rule of thumb is when everything fails, examine the patient. So you need to examine a patient. You cannot do this by telehealth. What you need is to objectively correlate all the symptoms that are presented over the past 5 years. I examined her hands and wrists show full range of motion. She was tender at the joint margin, but there was no swelling. I look at her eyes, they were slightly injected, but a Sherman's test in my office showed normal wetting. Her mouth showed normal dentition, normal salivary pool. There was no thrush. The only thing I found was tender points and tender muscles, but without muscle weakness. Labs that were presented to me when she came showed a normal CBC, comprehensive metabolic panel, normal set rate CRP. I recommended a CK and that was normal. Urinalysis was normal. I also recommended getting TSH and a free T4 and they were normal. ANA was repeated and now it's at a higher titer, 1 to 160 with a homogeneous pattern. They did a whole ANA panel with anti-DNA and so on, and they were all negative, including SSA, which is an antibody for Sjogren's syndrome. So what we need to do when the patient said they have dry eyes is to prove that they truly have dry eyes. You can do the simple Sherman's test in your office or refer them to an ophthalmologist for a tear breakup time and maybe even fluorescence staining if there is some worry about that. We also can check for salivary flow by simply drying up the mouth and then look at how much saliva is produced over 1 minute. If there's a copious saliva pool, then it is normal. My dear colleague, Andy Saxon at UCLA, had the Saxon test, which I do sometimes, which is simply weigh a piece of gauze in your office, let the patient chew it for 2 minutes, obviously without swallowing it, and then weigh it again. And if it is less than 2.75 grams of saliva, it is abnormal for stimulation of saliva flow. So the conclusion after all these testing and exam is that she suffers from fibromyalgia, which is a syndrome characterized by chronic widespread pain, which means pain above and below the waist on the right and left side of the body. In 1990, they insist on tenderness to palpation at specific body size, 18 points, and you need 11 out of 18 for a diagnosis of fibromyalgia. We have since dropped that because there was a ridiculous recommendation anyway. Even back in 1990, when it was first proposed, I told my fellows at UCLA that if they only had 10 points, press very hard at the 11th point. So it's ridiculous. But now we do insist on chronic widespread pain. And it has no target tissue, but it's really quite easy to recognize if you know what the characteristics of fibromyalgia are. So why are we talking about fibromyalgia when this is a talk on autoimmune disease? And the reason is that you will be seeing it. 5 to 10% of general medicine clinics would be fibro. Rheumatologists, if they're lucky, it would be 15%, it could be higher. In the general population, it's estimated about 3 to 6 million people, with women being predominant. Dr. Wolf claimed that the ratio was 3% women, 0.5% men. Most of us in practice would say it's more likely 9 times women than men. And the most prevalent age is actually older, around age 50 or higher. Now, contrast that with lupus. If you look at CDC criteria and the ACR criteria for lupus, we're talking about at the most 300,000 people in the United States, which means that the likelihood of you seeing somebody with fibromyalgia at 3 to 6 million with a positive ANA is about 10 times the truly seeing lupus. Here is simply another breakdown showing you the separation. Let's see if yeah, good. Fibro is 3 to 6 million. SLE is about 300,000. RA is about 1.5 million. Psoriatic arthritis, about 1 million. And when you look at the Cleveland Clinic cohort for fibromyalgia, you see that many of these multi-system problems can really confuse you about a serious underlying autoimmune disease: fatigue, widespread pain, depression, unrefreshed sleep, headaches, difficulty concentrating, memory problems, urinary frequency, culture negative UTIs, constipation with diarrhea, irritable bowel syndrome symptoms, depression, and anxiety. I'm sure there's a shock of recognition for people in this room that many of your patients probably fit into that cohort. And the paradox of fibromyalgia is that despite the symptoms, is they have normal range of motion, no mechanical or minimal mechanical disability, inhibited really by pain, no true muscle weakness or atrophy. Labs should be entirely normal. We're doing labs to exclude other things, and everything that you want to do should pretty much be normal. So, faced with that question, what do I do when I see somebody that come in with a multi-system illness? This is my panel. CBC, comprehensive metabolic panel, looking at electrolytes, calcium, liver, kidney function, CK if they have a lot of muscle symptoms, urinalysis, SED rate, CRP. I do both. And a TSH to look for evidence of hypo or hyperthyroidism because they usually would mimic an autoimmune disease with multi-system complaints. Only if I detect joint synovitis would I then do rheumatoid factor and an anti-CCP, and I'll come back to that. And then the ANA, if it is positive on referral, probably good idea to repeat it, and maybe if the circumstances demand it, to do the full panel. So how do I identify an inflammatory arthritis? Inflammatory arthritis have two targets. Rheumatoid arthritis, the major target is the lining of the capsule on the inside, the synovium, which is normally one layer thick, but in rheumatoid arthritis, there's tremendous inflammation and proliferation. And a lot of the damage in the joints is caused by this unchecked proliferation of the synovium. But there is another group of diseases, the so-called seronegative spondyloarthritis, including psoriatic arthritis and ankylosing spondylitis, when there's a second target called the enthesis, where ligament attaches to bone. So this is typical RA, symmetrical polyarthritis. It is perfectly symmetrical. When you split the patient down the middle, the right side looks like the left in terms of the inflamed joints. And here you see them, MCPs, wrists, PIPs, but not the DIPs. Why not the DIPs? Because there's very little synovium at the DIP. So ANA is positive in about 30 to 50% of RA patients. And it doesn't mean they have lupus, combo RA and lupus. The majority of them have nothing but RA. But if the titer is positive and is high, it's a good idea to ask them about dry eyes, dry mouth, because Sjogren's syndrome would show that particular pattern. So here we look at a normal joint and a joint affected by RA, and you see that the loss of cartilage, the damage to bone, the swollen joints, the tender joints are all caused by this proliferative synovium. And here you see it, this boggy synovitis. We also require that the arthritis be present for 6 weeks. So if it's less than 6 weeks, we worry about this being a viral arthritis that is short-lived. And here you see the distribution. It's symmetrical polyarthritis, shoulders, elbows, wrists, MCPs, PIPs, but not DIPs. Hips, knees, ankles, MTPs. But look at the skeleton. It is completely normal, other than rarely in very severe active RA, there is some inflammation at C1, C2, the atlantoaxial joint, because they're little synovial structures, and that can cause atlantoaxial subluxation, which means that when your patient comes in with a polyarthritis, but also very prominent neck, thoracic, back, sacroiliac symptoms, you're not dealing with RA, you're dealing with something else. Here you see the bone scan showing the distribution, symmetrical light up, nothing at the DIP. So when you examine the patient, always examine the feet, even though they may not be symptomatic, because we pick up early RA very commonly at the metatarsal joints. And when you squeeze the toes together, it is very uncomfortable because of the distended capsule. And if they walk on it, it is uncomfortable because the little tissue pad is displaced anteriorly and they're walking on the naked metatarsal head. The space between the toes is wider, and later on they get callus formation at the bottom of the foot. This is probably what you will be seeing in most patients who present with early RA. We look for nodules, which could be very obvious or rather subtle. But you see in the textbook all these findings for RA, right? Swan neck deformity, boutonniere deformity, collapse of the thumb, ulnar deviation, severe muscle wasting, carpal tunnel syndrome with wasting of the thenar muscles, numbness and tingling, sensory loss in the first 3.5 fingers, subluxation at the wrist, dissection into the calf with pseudo thrombophlebitis, flat feet like this from chronic inflammatory arthritis. I submit to you that you should not be seeing this going forwards. We manage RA so well now that 80% plus of the time we can control pretty much all symptoms of rheumatoid arthritis. And if they present to me within 2 to 3 years of diagnosis, they should not be developing these deformities. So these are chronically from the past, but we shouldn't be seeing it in our current day and age. So we do x-rays when we have such a patient. And I repeat them every year until the disease is completely under control. Because if they develop erosive changes, joint space narrowing and damage, I have not controlled the disease well. And we look very carefully for joint space narrowing, soft tissue swelling, erosions, and also juxta-articular demineralization when they lose mineral content. This x-ray looks normal except for maybe some narrowing at the couple bones. And the erosions appear very early. It is a mistake to think that because the disease is only, a few weeks old, only 8 weeks, 12 weeks, why should we x-ray them? Well, most of the x-rays appear early. And in fact, in the Dutch population in early RA, about 25% had erosions at the time of presentation, even though they say that disease had only been for a month or so. And when you look at this curve here, you see that the feet, the metatarsal joints, are much more sensitive than the hand, you see? So that is the reason why, even if they're not very symptomatic, when I get x-rays, I x-rays the hands and the feet, and I look carefully at the MTP joints. So in the hand, this is one of my patients who presented with a 6-month history of RA, and you can see a few erosions in a couple bones, some joint space narrowing. I put on a methotrexate, and 6 months later, we repeated the x-rays, and there were more erosions. This means that the methotrexate, even though clinically she was much better, it was not controlling the disease. And I ended up adding a TNF inhibitor. So progression has to be followed by x-rays. So we require that RA have 3 or more joints that are inflamed. We look for rheumatoid factor and anti-CCP antibody, and one or both should be positive. Set rate should be elevated, or C-reactive protein, or both. Now, so those are the strict criteria. We also quickly think through other conditions that may look like RA, like psoriatic arthritis, viral arthritis, polyarticular gout, and even lupus. I'll come back to that. And the duration has to be more than 6 weeks. Because when you use 6 weeks, then pretty much all the viral arthritides are gone. The only 2 exceptions are chikungunya virus and parvovirus B19. Those 2 viruses can sometimes cause polyarthritis for up to a year. So other than those 2 viruses, if you're looking at Coxsackie, echovirus, enterovirus, hepatitis A, B, and C, HIV, they're all very, very short-lived. COVID-19 doesn't even cause an arthritis, just arthralgia and myalgia. So we do Separate and CRP because they tell us that there is some evidence of general systemic inflammation. I do rheumatoid factor, and it should be positive in 80% of patients, anti-CCP in about 70% of patients. ANA, I'll come back to, okay? It doesn't imply a diagnosis of lupus. So with these two antibodies, we're looking at the spectrum of RA. Rheumatoid factor can be a late antibody. What does that mean? That means that when you get the polyarthritis, rheumatoid factor can be negative. It is a good idea to repeat the rheumatoid factor in 6 months and 1 year because some of them will turn positive because it is a late marker. Anti-CCP is a very, very early marker. In Army recruits, it was positive 14 years before the onset of RA. So if it is negative at presentation, it doesn't have to be repeated because it's going to stay negative. So we have 3 separate compartments: the double positives, the single positives, and the double negatives. The double positive are bad news. You really need to be aggressive because those are the ones that go on to develop erosions and joint deformities if you don't control the disease very well. The single positive simply tells you that you made your diagnosis. And the double negatives are always a problem too. We keep an eye out to see if something else is going on. Do they then later develop lupus? Do they develop Sjogren's syndrome? Do they develop polymyositis? Because many of those conditions can initially present as double negative, or they can stay double negative for the rest. And they tend to have milder disease than the double positives or the single positives. Dr. Maximovich in Canada recommended that if you have double negatives, do an extra test, 14-3-3 ADA. This is available through Quest Diagnostics. You can order it. And he claims that if you do all 3 antibodies, you pick up roughly 90% of early RA. So you only miss about 10 or 15%. So the positivity of any of those 3 would suggest that you're dealing with RA. Now, let's say you say, I don't feel comfortable treating rheumatoid arthritis. When should I refer somebody that I suspect of having RA? So what you want to do is to look at this. If they have 3 or more swollen joints, if the metacarpal or the metatarsal joints are involved, if there's morning stiffness for over 30 minutes, you should refer them. Because this is the way to pick up early RA. Dr. Smolen in Austria, the Leiden Clinic in the Netherlands have set up early arthritis clinic. And we tried to do it when I was in practice with my colleagues. We tried to tell the front office to ask for this. If they suspect early RA, we try to see them as soon as possible. So these are the referral criteria. Quickly, psoriatic arthritis or PSA, ANA is positive in 1 to 30% of patients. ANA is meaningless in the context of PSA. It doesn't mean they have lupus. It doesn't mean they have more severe disease. I'll come back to why some of them are positive. It is really the background positivity most of the time. So you look for psoriasis. Psoriasis should be present about 85 to 90% of the time when they present with the arthritis. It's only about 10 to 15% of people with psoriatic arthritis and normal skin. But unfortunately, the psoriasis can be very subtle and affects only about 3 to 4% body surface area. They are not florid psoriasis that you see in a derm clinic. You have to look for them. In the scalp, behind the ear, in the belly button, on the elbow. You have to look for the psoriasis. And 80% of the time, it's going to be plaque psoriasis like this. If they present with other patterns that look like this, I usually get a dermatology colleague to confirm that this is truly psoriasis, but you should be able to find psoriasis quite often. Now, psoriasis is present in about 2 to 3% of the general population, but only about 30% of them develop true psoriatic arthritis, which drops it down to about 1%. So it precedes the arthritis or occur at the same time as arthritis, 75-15. So 90% of the time, you should be able to find the psoriasis. 10% is pattern recognition because they don't have psoriasis at the time of presentation. So how do you diagnose PSA? Well, look for nail pitting and onycholysis. That should be present in 80 to 90% of psoriatic arthritis patients. Only about 40 to 50% of people with psoriasis, but no arthritis. So this is really a marker for psoriatic arthritis. The problem with psoriatic arthritis is that besides the synovitis, there's an additional target called the antithesis. So where ligament attaches to bone, here you see the inflammatory cells. This is called enthesitis or enthesopathy. And up and down the spine, there are strong ligaments around the sacroiliac joint at the symphysis pubis. So back spine involvement is prominent in psoriatic arthritis. And here you see asymmetric involvement in the spine. Ankylosing spondylitis is a symmetrical disease. You see this bamboo spine. Psoriatic arthritis in the spine is very asymmetric. Psoriatic arthritis is very asymmetric, which is another way to distinguish PSA from RA. So they have DIP involvement. You never get DIP involvement in RA. And the reason for that is that this is an enthesitis in miniature, coming from the nail bed into the DIP joint. So DIP involvement is quite common. And you see sausage digits, sausage toes. The entire toe is swollen. The entire finger is swollen. You never see this in RA. In RA, the swelling is confined to the capsule. Here you see synovitis and synovitis here, but the rest of the finger is normal. Whereas in PSA, the whole digit is swollen. Why? Because this is not a true synovitis. It is an enthesitis of the ligaments and tendons going up and down that finger. So when you see a swollen finger, when you see a swollen toe, when you see DIP involvement, think psoriatic arthritis. It can even occur in the heel here, causing swelling and pain. It is not in the ankle joint, but where the Achilles tendon attaches to the calcaneus or when the plantar fascia to the calcaneus. So we examine the swollen ankle in psoriatic arthritis and find that the inflammation is here or here. I tell my podiatry students who rotate through UCLA that the frequent plantar fasciitis that they may see, look for psoriasis because that could be a presenting feature. The main differential between RA and PSA is symmetry. As I mentioned earlier, RA is a very symmetrical disease. PSA is a very asymmetric disease. This risk, not that risk. This MCP, not that one. DIP involvement. So when you see asymmetry, right elbow, left knee, right wrist, left MCP, but not the right, think about psoriatic arthritis. Look for the psoriasis, look for the nail changes because you're not dealing with RA. So asymmetry, spine involvement, sausage digits, no nodules. And the psoriasis, as I said, could be subtle and easily missed. You have to ask the patient, you have to examine them. The patient doesn't know that the skin has anything to do with the joints, right? They come to see you because the joints are painful. All right, let's talk about lupus. So lupus can present as a symmetrical polyarthritis, but it tends to be migratory. Or it could be arthralgia. That is, they are painful, but when you examine them, they're not markedly swollen. So how do you tell SLE from RA? Well, It is the company it keeps. So a lupus patient early on would have a low-grade fever sometimes, weight loss most of the time, or weight gain if they have lupus nephritis and heavy nephrotic syndrome, low albumin, for example, with edema. Synovitis, it could be migratory, polyarticular, but it should be symmetrical. But you need to examine them. The malar rash is quite prominent, but the other rashes may not be that prominent. Photosensitivity, ask them about sensitivity to the sun, and then oral ulcers, which are typically painless. So you need to look for them. Look into the nostril, look into the throat, look at the palate, see if you see shallow, painless ulcers. They are quite common in lupus. You do a complete blood count, urinalysis, set rate, CRP. These are the inflammatory markers. I do a comprehensive metabolic panel, TSH, and CK. So this is my lupus baseline test. But what kind of labs would it show? Well, maybe an anemia of chronic disease, white count a little bit low, particularly lymphopenia, platelets low, 110,000, not enough to spontaneously bleed. Urinalysis shows protein, very important. Red cells, very important. You're not going to see white cells and casts until later on with florid nephritis. SED rate would be elevated, 30 with inflammatory disease. CRP is normal. I'll come back to that. CK should be normal, TSA should be normal. So when you see labs like this, you worry that something else is going on, particularly the protein and blood in the urine. That puts her away from the RA category. So ESR and CRP are raised in a number of conditions. In obese people, they tend to be mildly elevated. This is a big problem. If I presented that fibromyalgia patient to you and she has a BMI of 40, she could have a SED rate of 25, she could have a CRP of 1.1, and then we'll say, well, she's inflamed, she couldn't be fibromyalgia, but it could be simply the obesity that is doing it. But in lupus, even with active disease, CRP is normal. It is only elevated if they have infection or some other reason. So an elevated CRP in lupus make you look for something else. Very interesting. SED rate is high. SED rate could be high in people with renal failure, even if they don't have any inflammation, or older people. And obviously a gammopathy, if they have a MUGUS, a monoclonal gammopathy of unknown significance, the SED rate could be sky high, but they're not inflamed. So what is lupus? The best way to think of lupus is that it is an immune complex disease caused by antibodies against body tissue like DNA, RNA, and they develop these antibodies and they form immune complex disease. I'll show you what it means and why that's a very useful thing to keep in mind when you try to sort out the complicated symptoms of lupus. The problem with lupus is that it is diagnosed by committee. It may not be one single disease. No two lupus patients in my practice have exactly the same symptoms. So it may be a spectrum. It could appear over time. You may be able to control somebody's lupus very well, but then several weeks, months, years later, they develop nephritis with renal, with high protein and reduced renal function. So you have to be vigilant all the time when you treat lupus because the symptoms may not appear all at the beginning. And genes and environment play important roles. So lupus also is different in different races. It is more common among the non-white population. So, for example, African Americans will have a higher prevalence of lupus, and Caucasians have a lower prevalence in my own experience than my Chinese patients in Singapore or in Taiwan or in China or Hong Kong. So we see differences. We also see differences in the prevalence of severe problems. Kidney damage occurs a lot faster in the Hispanic and the African American population. In my experience, lupus in the Chinese population was a lot more aggressive. I saw transverse myelitis when I was teaching in Singapore. I hardly ever see that among my Caucasian patients in America. So RA tend to be milder in Asia, whereas SLE tend to be a lot more severe. And it is a ubiquitous disease, but it is rare in Africans, very common in African American. So the genes play a major role. Also, UV light could be a trigger, sulfur drugs, estrogen, smoking. We think EBV may play a role, and there's a lot of very great interest in the microbiome in lupus to try to diagnose it early, what is going on in the gut, and to try to change the microbiome to see if we can improve the disease. So the prevalence is about 5.6 per 100,000 generally, but in the young African American blacks, it could be as high as 406 per 100,000. So 4 per 1,000 is the highest prevalence of lupus. So Black women have a 7-fold greater prevalence of end-stage renal disease, unfortunately. And the disease is more severe in Asians and Hispanics compared to whites, as I mentioned. So how do we diagnose lupus? Okay, so they come in usually with a variety of complaints, and it could involve a variety of different symptoms, but inflammation is probably the reason why they have these symptoms. And the most common pattern is a mixture of fever, weight loss, malaise, linked with skin rashes, musculoskeletal symptoms, muscle pain, weakness, joint swelling, mild hematologic and serologic involvement. Look at this pattern. It looks like fibromyalgia, other than the fact that CBC should be normal in fibromyalgia, and that shouldn't be involvement of serology, which I'll come back to. So this is 1,000 patients with lupus that was followed since 1991. And you can see that arthritis, malar rash, fever, photosensitivity, kidney involvement, serositis, pericarditis, pleuritis are common. These are the new ACR criteria in 2019 for diagnosing lupus. You need an entry criterion that the ANA has to be positive at 1 to 80 or higher. ANA negative lupus doesn't exist anymore. Don't diagnose it. So they have to be ANA positive. Then you start adding up points here. And if it reaches 10 or greater, you have the ACR classification criteria for SLE. I like to go over some of these points one by one because they're very helpful. So what are the symptoms in terms of clinical features? Fever, you get 2 points. Leukopenia, 3 points. Thrombocytopenia or hemolysis, 4 points. You don't add up the points. You choose the highest of the group. So this will be 2, this will be 4, even if all 3 are positive. Neuropsychiatric, delirium, psychosis, seizures, 5 points. Non-scarring alopecia, oral ulcers, subacute cutaneous or discoid lupus. I'll show you example, and acute cutaneous lupus. So again, you get 6 points maximum here. Pleural or pericardial effusion, 5 points. Pericarditis, 6 points. Joint involvement, 6 points. Proteinuria greater than half a gram in 24 hours, 4 points. And then you do renal biopsy. If you get a kidney biopsy that is classic for lupus, on its own, 10 points would classify that patient as lupus. So the renal biopsy is very important to secure the diagnosis of lupus. What about blood tests? You should get, if the ANA is positive, you should get ntDNA and NTSM because that would give you 6 more points. You should look at serum C3 and C4 because that would give you additional points if they're low and they're consuming complement, part of the autoimmune disease. And I would also recommend ordering antiphospholipid antibodies because if they are positive, you get 2 points. So if you suspect lupus, get a 24-hour urine for protein and see if it exceeds 500 milligrams. Look at C3, C4, see if they are low, get anti-DNA, anti-SM, and the anti-phospholipid antibodies. So ANA is simply nuclear tissue on a slide. You add the patient's blood. If this antibody binds to the nucleus, you now add a fluorescein label anti-immunoglobulin. So this is a sandwich technique. A attached to B, C attached to A, C lights up under ultraviolet light. This is called indirect immunofluorescence. And what you see are patterns on the nucleus. They could be homogeneous, they could be rim just around the rim, they could be speckled, or they could be nucleolar in the nucleus. So the pattern sort of tells you what part of the nucleus is reacting to those antibodies. So if it is homogeneous, it is the nucleosome, which is the protein core where the DNA wraps around that protein core. We see this in RA, in lupus, and especially in drug-induced lupus. So drug-induced lupus very commonly present, it's a homogeneous pattern, and you get anti-histone antibodies. That's why anti-histone antibodies are classic for drug-induced lupus. You also see LE cells. We don't do LE cells anymore. I don't even know whether your lab is good enough to do LE cells. But when I was a resident and fellow, I did my own LE preps because there was a way to pick it up. And it is still worth getting it in pleural or pericardial fluid because that really suggests lupus if you see these LE cells present. Nucleolar pattern typically seen in scleroderma and Raynaud's phenomenon. Speckle pattern, which is, by the way, the most common pattern we see now, is a whole bunch of different antibody. SSA, SSB would be Sjogren's, SM would be lupus, anti-RNP might be what we call mixed connective tissue disease, anti-dense fine speckle 70. If your lab reports DFS 70 positive, ANA with a speckle pattern, what is the diagnosis? The diagnosis that she is normal. In fact, normal people with positive ANA and a DFS 70 pattern have a lower risk, I repeat, a lower risk for autoimmune disease than the general population. So DFS 70 is a normal finding. The rim pattern classically would be DNA, double-stranded DNA, lupus. We also use a protozoan called Crithidia. Crithidia has got a tail, a flagellum, that is driven by something called the kinetoplast. The kinetoplast is pure double-stranded DNA. So if you are worried that the double-stranded DNA is not specific, by the way, single-stranded DNA doesn't mean anything. Forget about single-strand. Double-stranded DNA is for lupus. But if you're not sure, order Crithidia lucilii anti-DNA. That is the best test for picking up anti-double-stranded DNA. DNA is actually not just an antibody, but it can cause damage to tissue. It goes up and down. When the disease is active, the level is high. When it's better, level goes down. So we follow anti-DNA. So if I see a patient here and her anti-DNA is very high, I treat her and she got better. Now I see her here and it's going up, even though clinically she feels well. What I do then is bring her back more frequently. Instead of seeing her every 4 months, I might say, Mrs. Smith, why don't I see you in about 6 weeks? Because I'm concerned that the clinical features may be coming up when the DNA goes up. Centromere is a very useful pattern. When you pick that up, you're dealing with something called the CREST syndrome. So Raynaud's phenomenon is the R, C is calcinosis, esophageal motility problem, sclerodactyly, and telangiectasia. So centromere pattern strongly suggests the CREST syndrome. And here you see the CREST syndrome. Purple fingers with co-exposure, then they turn white, then they turn purple, then they turn red. Sclerodactyly. Distal to the MCP, the fingers are tight, the skin is tight. Calcium deposit, esophageal motility is the pattern. ANA is very sensitive now. It picks up over 99% of lupus patients, but it's got a false positivity of 15%. And even people that are normal with false positive ANA can have high titers. So high titer in the old days would definitely suggest lupus. But nowadays, we're not sure that even if the ANA is more positive, like greater than 1 to 320, they could still be normal. Now, the anti-DNA is more specific, but anti-DNA is only seen in about 80% of people. Anti-SM is all very specific, but only 10%. So you cannot rely on these two to diagnose lupus. They're good for confirmatory. We now do lupus with a bead assay, right? It goes through this machine and it counts the different antibodies. And usually you get a panel like this, and you look like chicken soup or duck soup or whatever. You say there's so many things. Well, the good news is that the tests are very reliable and sensitive. So this is for real. But you need to sort out what it means. So double-stranded DNA or criteria or anti-SM would be lupus. And then the other antibodies will direct you to other diseases. Here would be antiphospholipid syndrome. Here it would be Hashimoto's thyroiditis. This would be interstitial lung disease with polymyositis. This would be scleroderma. So it can lead you to different directions. And you see the positivity linked to different disease. But I want to bring your line down to here. Fibromyalgia, 15 to 23%. That is why a positive ANA could be just as likely fibro, much more likely than lupus. So don't diagnose negative ANA, negative lupus. The only time we worry about subacute lupus are really children that are born with skin rashes, and we check the mother, or children that are born with congenital heart block. The mother could be totally asymptomatic, but they may have anti-Ro and anti-La antibodies. So anti-SSA antibodies crosses the placenta and binds to the fetal conduction system early in life, and the kids could be born with congenital heart block. You see this subcutaneous lupus, the mother is totally asymptomatic, but she was positive for anti-SSA. That crosses the placenta, and the kid gets a subcutaneous lupus. So what do I do when I get a positive ANA? I get a complete history. I fully examine the patient. Don't do telehealth medicine to diagnose lupus or fibromyalgia. You need to document presence or absence of pathology. Do the panel. If it's autoimmune suspicion, do the panel. Look for the whole panel. Consider antithyroid peroxidase. Why? Hashimoto thyroiditis is a very common reason for positive ANA in the young women that you see in your practice. I review all the medicines. Are they on procainamide, hydralazine? Could this be a drug-induced lupus? I look at family history. If a mother has lupus, she has a much higher risk of getting lupus, right? I look for thyroid disease. I look for an intercurrent viral or bacterial infection. They cause positive ANAs. You get COVID-19, your ANA will turn positive. But when you get better in a few weeks, the ANA becomes negative. So don't use ANA as a screening test. Only do it when you suspect autoimmune connective tissue disease. Why? Even though it is so sensitive, its specificity is only 85%. But because lupus is a rare disease, the most common, the highest prevalence of lupus is 4 per 1,000 base rate. So if you test 1,000 women, you're going to pick up 4 lupus, but you're going to pick up 150 false positives. Because if I were to do an ANA on everybody listening to me today, 15% to 17% of you will be ANA positive. So just for the ANA, the positive predictive value for lupus is 4 divided by 154, which is 2.6%. That is why all laboratory studies in rheumatic disease have to be geared to the clinical history and physical exam and can never be interpreted on its own. You say, well, the titer went up. This lady had 1 to 80, went up to 160. The pattern changed from nuclear to homogeneous. What does that mean? It doesn't mean a damn thing. Here are 6,000 plus patients at the Cleveland Clinic that had the ANA done over a period of 20 months. Over 20 months, normal people, positive ANA, 1/3 went up, 1/3 went down, 1/3 stayed the same. How about lupus? 50 true lupus patient, 21% went up, 44% didn't change, 35 went down. So the titer going up and down doesn't mean it's for real. It could still be a false positive. So it's an immune complex disease, and it's the binding of antigen and antibody in the middle intermediate complex that causes the damage in the blood vessels, activating complement. You get the rashes, malar rash, photosensitivity. You see this lupus band, the immune complex there, malar rash, sparing of the nasolabial fold. This is rosacea, and the nasolabial fold is not affected. You see here the sparing of the nasolabial fold in malar rash of true lupus. Discoid lupus with a lot of scarring, pleuritis, pericarditis. Why? The immune complex is trapped in the lung lining in the pericardium, causes inflammation. Synovitis, trapped in the synovium. You can get this so-called Charcot arthropathy with chronic lupus. In the brain, you can see this binding to neurons. You can also get clots, you can get little congestions like this. But strokes, it would not be part of lupus cerebritis. You worry about antiphospholipid syndrome. Kidneys, very common. You see the basement membrane, the complex get trapped there, destroys the membrane. You get this lumpy, bumpy immunocomplex here in the endothelium. Kidney biopsy shows proliferation, obliteration. Here you see proliferative GN, lumpy, bumpy immunofluorescence, kidney involvement. So once you understand immune complex disease, the symptoms of lupus make sense. It is simply these complexes that they get trapped in different tissue compartments, activate complement, and causes inflammation. So when you do an arthritis panel, what do? You do SED rate, CRP, rheumatoid factor, anti-CCP, ANA. Some people do uric acid, HLA-B27, CBC, and a CK. This is crazy, okay? Why do a uric acid in a young woman? They're never going to get gout unless they have synovitis. Rheumatoid factor, anti-CCP may give you false information. ANA is positive in 50 to 70% of normal people. So you should not do an arthritis panel. Thank you very much. Questions? So Dr. Miller, any questions from the audience?
Doesn't sound like it, or doesn't look like it. I just, again, just want to thank you very much for the time. Great talk. And I know I learned a lot. Practice